Hello, my name is Caitlin Vandiver, and I will be presenting on peptic ulcer disease. So my case study today is Miss P, who is a 35-year-old female, and she is presenting to the office today with pain to the abdomen on the upper right quadrant. During the assessment, Miss P states that the pain usually starts about an hour after she eats, and she also thought that it was just heartburn since the pain subsides after taking Tums, but it does come back. So Miss P denies nausea and vomiting or any other symptoms. No abnormalities were found during the assessment. Miss P does not have any health history to note. Both she and her family are very healthy overall. Pathophysiology of peptic ulcer disease shows that it has about three main diagnoses. The first one is a duodenal ulcer. This one is the most frequent. It's caused by acid and pepsin concentrations which occur in the duodenum, and that penetrates the mucosal barrier, causing the ulcer. It can cause chronic intermittent pain, and it begins about 30 minutes to 2 hours after eating. Typically, a duodenal ulcer will show up between the ages of 20 to 50 years old. You might have a positive family history. There's no gender prevalence. It happens in both men and women equally. No significant stress factors. However, there might be increased use in ulcerogenic drugs. And there's no increase to cancer risk as well. So in about 95 to 100% of patients, H. pylori infection is seen if they're diagnosed with duodenal ulcers. Unfortunately, with the duodenal ulcer, when a client eats or takes an antacid, it helps relieve the pain. This in turn can cause a pain, antacid, or food relief pattern, which means that anytime they're feeling pain, they'll continue to eat or take too many antacids in order to relieve that pain. Some individuals, however, do not have any symptoms, especially in older adults, but the first manifestation could be hemorrhage or perforation, especially if they have a history of NSAID use. The next type of ulcer is a gastric ulcer. It's located in the stomach, and it's caused by an abnormality that increases mucosal barriers' permeability to hydrogen ions. It can also be caused by a duodenal reflux of the bile. Typically, this happens right after the patient eats. They begin to feel some pain. You'll see it in ages more than likely between 50 and 70 years old. Family history is usually negative, and again, just like a duodenal ulcer, there is no gender prevalence. It's equal between men and women. These may happen in an increased rate due to stress, and it also has an increased risk for cancer as well. In about 60 to 80% of gastric ulcers, we will see the H. pylori infection compared to a duodenal ulcer, which is about 95 to 100%. The third type of ulcer is a stress ulcer, or stress-related mucosal disease. This is an acute form of peptic ulcer that is usually accompanied with physiologic stress, such as severe illness, major trauma, multi-system organ failure, and we might even see it in burns and head injuries. Usually there's a lot of sites that may be distributed all throughout the stomach and the duodenum. So how can we evaluate for a peptic ulcer? We must differentiate between gastric and duodenal ulcers and even differentiate between a gastric carcinoma and these ulcers. So the best route is to use endoscopy. This allows visualization of lesions, and we can also obtain a biopsy which will detect H. pylori infection. We also check gastrin levels, take a urea breath test, we check serum antibody levels, stool, and also serum antigens. Both duodenal ulcers and gastric ulcers are evaluated in the same way, so these tests would all be used for both. So how do we treat peptic ulcers? Obviously, we need to relieve the cause and effect of hyperacidity and prevent further complications. So antacids can be used, and they usually are used very widely because it can relieve pain elevate pH, neutralize gastric contents, and also inactivate pepsin. Medications are also used, such as proton pump inhibitors, sucralfate, anticholinergics. Now, if you've ever worked at the hospital, you've probably seen just about every single patient on a proton pump inhibitor, and this is usually done prophylactically, even if they don't have any GI diagnoses. We need to eradicate H. pylori infection, and we can use bismuth and different antibiotics with added vitamin C in order to prevent any relapse that may occur. Surgery could be necessary if we see bleeding, perforation, obstruction, or peritonitis. And we need to increase vitamin A and fiber in the patient's regular diet.